Good evening,
Okay,
everyone.
so one
Good
quick
evening, everyone.
thing.
Thank you so much for joining this meeting. This is our June monthly meeting for the Nigerian Society of Colorectal Disorders. My name is Dr. Ademola, the president of the society. And this evening we have Dr. Adedapo Osinowo, who is an assistant professor of surgery with Lagos University Teaching Hospital and the College of Medicine, University of Lagos, to talk to us about rectal cancer management, addressing therapeutic challenges, especially now unique situation. I recognize every one of our teachers, our colleagues, our friends who have joined this meeting. We have at least 32 people on the call at the moment now, and we are grateful for this. And without further ado, we would hand over the platform to Dr. Shinoma to start the presentation. Over to you, sir.
Yeah, all right. I don't know what to say. Is it good morning, good evening, good afternoon, everyone? But I think that proper thing to say good evening, everyone. Can you all hear me? Are we
We can
good?
hear you,
Can you
sir.
all hear me, please?
Yeah,
We
we
can
can
hear you,
hear
sir.
you.
Can you hear? All right, I can go. Yeah, good. I'm going to go on. So we're going to be discussing rectal cancer management, and we're going to address some therapeutic challenges. Some of these therapeutic challenges I'm going to discuss are challenges that we faced in my facility. So let's go ahead and start discussing rectal. We're going to go right. We all have to appreciate one thing. Colorectal cancer in Nigeria is projected to increase both in incidence and mortality as we go into the 2040s, right? Unfortunately, the younger population will bear a disproportionate burden, which is going to be a worrisome trend for policymakers, because when you have young people that are supposed to be productive falling ill, having colorectal cancer, and we all know what the situation is in Nigeria. Diseases are usually diagnosed when they're locally advanced. And clinical data actually shows that when it comes to colorectal cancer, there's a higher prevalence of rectal cancer compared to colon cancer in Nigerian cohorts. Rectal cancer treatment evidently will ultimately pose a significant burden on healthcare systems in Nigeria. Unquestionably, because Nigerian population is increasing, the younger population is increasing, and rectal cancer treatment is a condition that is evolving. It's quite dynamic and is evolving. It's been evolving over many years. It used to be surgery centric, but is now a multimodal image guided strategy. Multimodal image guided. Which image are we referring to? In this day and age, you can't do rectal cancer treatment without MRI. If you don't have MRI, you're not doing the right thing for your patient. Over the years, rectal cancer treatment has been, the landscape for rectal cancer is, like I did say, is dynamic and it's been evolving, has an evolving landscape. The key historical advances were: one, standardized TME. We all know what TME is, total mesorectal excision, that was pioneered by Bill Hill. Incidentally, I met Bill Hill in 2015 when I was at Stuttgart. I went for a laparoscopic colorectal thing. That's when I met him. Right? We talk about standardized total mesorectal excision, neoadjuvant chemoradiation for high risk tumors. I will define high-risk tumors later on in the topic. Then, of course, I did say your decision to do anything for a patient is going to be based on the pelvic MRI. The pelvic MRI is actually used for risk stratification. It's going to tell you whether you are low risk or high risk. They're also different. I did say that rectal cancer treatment has an evolving landscape. There are recent developments. Everything is geared towards organ preserving. You don't want to remove the rectum. Nobody wants to remove their rectum when they have cancer, right? One, we have the watch and wait policy. That's the non-operative treatment for patients who have achieved complete clinical response after total neoadjuvant therapy or chemoradiation. Then surgery is delayed, right? Surgery is delayed. Then in some cases, the patient presents early, which we rarely see in Nigeria. You can have a local excision, which is transanal endoscopic microsurgery for early stage disease. There are specific criteria for that. for all these conditions, for treating those patients. Then, of course, you have total neoadjuvant therapy, which is a new development. New development has been around for about 5-10 years, a new development. And more recently, immunotherapy. Immunotherapy is for a super selected, I think the super selected group of patients that have a mismatch repair deficient tumors. They are given immune checkpoint inhibitors that they've been very promising. They all respond, the ones they used had good clinical response. And of course, what we all do, what most of us do, is the sphincter saving resection, low anterior resection or ultra low anterior resection. These are the developments that have happened over the years. The rectal cancer, these strategies, more recently, all these most recent strategies, whether you're doing more like watch and wait, you're doing a low anterior resection, you want to do a local resection, all this will depend on imaging. If you don't have good imaging, pelvic MRI, the Mercury study that was done in England, I think it was in the 2000s, made pelvic MRI superior to other forms of imaging. All the strategies I did and I spoke about, for them to work, you need accurate radiologic staging to assess your treatment response, to know whether there's a recurrence, there's a regrowth, and you need those. So that's what made pelvic MRI, which is pivotal in guiding treatment decisions in rectal cancer treatment. It is now considered the gold standard for local staging and restaging in rectal cancer. And that's we also, rectal cancer management usually divided into early disease and locally advanced disease. If you look at the harmonized NCCN guidelines for sub-Saharan Africa, it actually made things a bit easier for everyone. Anybody that has any disease less than T2NO is considered an early disease. Anything greater than that is considered an advanced disease. For early tumors, that means T1NO, T2NO, depending on the risk profile, whether they can simply be managed. They're usually managed strictly by surgery, provided they don't have things like extramural vascular invasion, no mesorectal fascia involvement. Of course, T2 tumors won't have mesorectal fascia involvement. Of course, you don't expect that, but they shouldn't have extramural vascular invasion. These are low-risk tumors. The mainstay of treatment for these tumors are usually surgery. Whilst I did say that surgery is no longer centric in rectal cancer treatment, for the early disease, whether you're doing a local excision, you're doing a transanal endoscopic microsurgery, all these ones are done by the surgeons. Of course, the staging of the disease is going to be done by the pelvic MRI, which is still the gold standard. So rarely do you actually give them neoadjuvant treatment. Rarely do you need to give them neoadjuvant treatment unless you want to have organ preservation for early disease. Most early disease are either local excision. The criteria are usually, we should all know the criteria for local excision, and following, of course, the disease will have been staged with MRI, then you do endoscopy, you may need endorectal ultrasound for that as well. But for late disease, or I shouldn't use one late disease, maybe the appropriate term is locally advanced disease. The ones I spoke to earlier, I spoke about earlier, the early disease, T1NO, T2NO. Then anything after that is considered locally advanced disease in the context of rectal cancer management. Early disease, locally advanced disease that can be a T3, any N, or a T1 to 2, then N1 to 2. The mainstay of treatment now is total neoadjuvant therapy. The mainstay, this patient will have been staged. Of course, if you have a T3, any N, provided another concept you all have to appreciate when it comes to rectal cancer treatment is the term CRM. CRM means circumferential section margin. Once the circumferential section margin is not breached, it's clear, the patient should be offered total neoadjuvant therapy for a locally advanced disease. If they meet any of these locally advanced disease, they can either have long course chemoradiation first, then followed by FLUFOX or CAPOX, or FLUFOX or CAPOX first, then followed by long course chemoradiation. It can go either way. There's no hard and fast rule which one comes first, but it can go either way. The other alternative is you can also offer the patient neoadjuvant therapy, which is the long course chemoradiation. All these actually stated in the harmonized NCCN guidelines for sub-Saharan Africa. I look at it, it's actually been very, very helpful. It has been very helpful. It's very, very helpful. The other disease, the next stage are the following total neoadjuvant therapy, the patient should have endopelvic MRI. You now have to consider whether you're going to do a resection of the disease or not. Following chemoradiation, restaging MRI should be done at 8 weeks. Anybody that's had radiation, you don't waste money doing an early MRI. You should always wait for 8 weeks before you decide whether you want to have a resection or not. Your resection can be a low anterior resection, high anterior or natural low anterior resection. But if you have a group of patients that have responded very well, had a complete clinical response, no evidence of residual disease, on digital rectal examination, rectal MRI, direct diagnostic evaluation, a watch and wait approach should be used, can actually be used. It's being used now in rectal cancer treatment, but it should be used in centers. This management approach should be used in centers where they have experienced multidisciplinary team. You do not select a patient for watch and wait after TNT, total neoadjuvant therapy. We don't have a multidisciplinary team that will manage the patient. This multidisciplinary will come. The surgeon himself, the colorectal cancer, the surgeon itself, who is going to do the MRI, the endoscopist. These are things that must be in place. You must always have a multidisciplinary team in all these situations. If you want to do a watch and wait policy, otherwise called a non-operative treatment for a patient. For the next group of patients, their disease is a bit more advanced, right? The disease in this context, the CRM, the circumferential resection margin, is either involved or threatened. They have the same thing. Mandatorily, they must have long-course chemotherapy followed by FLUFOX or CAPOX. It could either be FLUFOX or CAPOX first or long-course chemoradiation. In this subsets of patients, you don't give them just radiation alone and go and operate. You don't give them, they must have both. They must have both radiation and chemotherapy. It can either be CAPOX or FLUFOX. Indeed, because the circumferential section margin is threatened or involved. This decision is made by using a pelvic MRI. Then following that, staging pelvic MRI is done. Then you have the options of if the tumor has been significantly downstaged and downsized, you can now decide, oh, am I going to do a transabdominal resection? Am I going to do an LAR, low anterior resection? Am I going to do an APR? Or I want to adopt a watch and wait non-operative approach, depending on the situation. If you have a good clinical response, you can go ahead and you have a multidisciplinary team that can manage the patient. You can adopt a watch and wait non-operative treatment. I hope at the end of this discussion, I would like to know how many doctors have had successful, good clinical response from total neoadjuvant therapy. I'd like to know. The pelvic MRI, like I did say, I've mentioned, I can't remember how many times I mentioned pelvic MRI. The pelvic MRI is the gold standard for staging. When you are staging this disease, there's quite a number of parameters you must consider. I'm not going to read everything, but of course you must know the T stage of the disease. Is it T1, T2, T3, T4? You must know whether the circumferential resection margin is involved or not, whether there are tumor deposits within the mesorectum, right? The end stage of the disease, presence of extra mesorectal lymph nodes. I've mentioned two concepts: circumferential resection margin, circumferential resection margin, and mesorectal fascia. I need to also tell you, I also need to emphasize that mesorectal fascia is used by radiologists. Circumferential resection margin is used by surgeon and pathologist. They all mean the same thing. When the radiologist is reading, it will talk about mesorectal fascia, why the pathologist or the surgeon will say circumferential resection margin. Those two concepts, I will explain them later. Yeah, these are all the other things you need to look at when your pelvic MRI is read. The report must state everything. All this, the circumferential location of the tumor, for T-stage disease, the extramural growth must be measured. All the presence of extramural vascular invasion. Because if a patient has extramural vascular invasion, even if he has a T3 disease, he must still go for long-course chemotherapy and long-course chemotherapy, long-course chemoradiation and chemotherapy. The morphologic pattern of the disease is also good. Annular, polypoid, mucinous also. It should also tell us that for completeness. Yeah, I did say I was going to talk about mesorectal fascia. This is a pelvic MRI. The area, the mesorectal fascia is that thin fibrous structure that actually is the fascia proper for the rectum itself. The fascia proper you can see on pelvic MRI, it appears as hypodense, hypointense. You can see the area in yellow, the area with yellow dots, with yellow arrows, is a thin fibrous structure enclosing the mesorectal compartment. It actually defines the anticipated resection plane during total mesorectal excision. That only plane that you go through is outside the mesorectal fascia or the circumferential resection margin. On a T2 weighted MRI, it appears as a thin hypointense line surrounding the mesorectum. The area here in the image to your right, the area, the hypointense line, that's shown by the yellow arrow is the mesorectal fascia. The mesorectal fascia, the radiologist calls it mesorectal fascia, while the surgeon and the pathologist calls it circumferential resection margin. That margin must not be breached by a tumor before you do any surgery. If it's breached by a tumor, the tumor must first be downstage or downstage and downsized using either chemoradiation or chemotherapy, or better use total neoadjuvant therapy. This is another picture here that shows this actually depicts, because I did say I can't overemphasize MRI when it comes to rectal cancer management. This picture, the one on the right, shows what we've been talking about. We can use interchangeably mesorectal fascia and circumferential resection margin. Look at the mesorectal fascia here. This is the mesorectal fascia. Is also the same thing as circumferential resection margin. Right. When you say circumferential resection margin is threatened, when the tumor is less than 1 cm, is less than 1 mm, most of them are T3 tumor. T4 tumors have already breached the mesorectal fascia. So they must have T4 tumors, whether it's T4B, T4A, they've already gone beyond the mesorectal fascia or the circumferential resection margin. So mandatorily, by protocol, they must have total neoadjuvant therapy, TNT. So let's talk about T3 tumors. T3 tumors, the ones in which the circumferential resection margin is either involved or threatened. When do you use that word involved or threatened? One, if the tumor is within 1 mm, it's less than 1 mm of the mesorectal fascia of circumferential resection margin. That's when you say the CRM is threatened or involved, or the tumor has literally invaded the circumferential resection margin. MRI involvement, circumferential resection margin involvement, or mesorectal fascial involvement is a contraindication to surgery. Patient must have total neoadjuvant therapy, because you are going to leave tumors if you go and do because the tumors are already outside your resection plane. So you're going to leave tumor behind if you go and do your TME. So the patient must have neoadjuvant therapy. So must have neoadjuvant therapy before resection. Neoadjuvant therapy is indicated to achieve tumor downsizing, and the mesorectal fascia will retract and ensure a tumor-free resection margin. Because when you do rectal cancer surgery, you must have a tumor-free resection margin all the time. It's needless going through that stressful surgery if you don't have a tumor-free resection margin. One of the challenges I'm going to discuss is a case in which we thought we had a tumor-free resection margin on MRI, and after surgery, it turned out differently. Yeah, these are the other criteria for mesorectal fascia involvement: tumor deposits, lymph nodes, or, like I did mention, if the tumor is less than 1 mm, less than 1 mm from the mesorectal fascia, you say the CRM is threatened. I've mentioned circumferential resection margin and mesorectal fascia, basically the same thing. The circumferential resection margin is used by the pathologist and surgeon. Circumferential is the closest distance of the tumor to the mesorectal fascia. Closest distance, if it's greater than 1 mm, clear circumferential resection, that means the tumor is very far from the circumference. It's greater than 1 mm from the mesorectal fascia. That means that's a clear circumferential resection margin. Involves circumferential resection margin. That means it's within 1 mm of the mesorectal fascia. But for lower third tumors where you don't have a mesorectal fascia, again, we are talking about is within 1 mm from the levator inner muscles or inner lesions invasion into the intersphincteric plane. So that's how it works. What are the therapeutic challenges that are faced as a surgeon, that we faced in our centers? There are actually 3 of them. We had to manage a colorectal anastomotic stricture. There was incongruity between MRI findings and the histopathology of excised specimen. I'm going to talk about, these are the 3 challenges we faced, and these are the 3 challenges I'm going to discuss. So the one that had anastomotic stricture was I'll give a brief history, and we'll talk about what led to the stricture and how we manage the stricture. 67-year-old man had locally advanced rectal cancer, had total neoadjuvant therapy with initial chemoradiation. Mark my words, I did say initial chemoradiation. There was residual disease. He had MRI done after he completed total neoadjuvant therapy. There was residual disease, so he was offered low anterior resection. It was offered low anterior resection about 5 months after he had completed chemoradiation. We did the low anterior resection without the protective stoma. Unfortunately, he had a leak. It required a redo laparotomy, repair of the anastomosis, and we had to fashion an ileostomy. He had an ICU admission. This was a surgery we did in about 40 minutes because it was a high octane, high energy surgery, because we almost lost the patient. But of course, the patient ended up in ICU. He recovered. He recovered with an ileostomy. But after he recovered, he did well. Before you close your ileostomy, you have to do a colonoscopy. We did a rectal examination for him to assess our area of repair. Lo and behold, this is what we saw. The proctoscopy revealed a stricture. We had to dilate the stricture to 16 mm using Eguare's dilator under spinal anesthesia before we could attempt closure of the ileostomy. Of course, following dilatation with Eguare's dilator, we had to do a gastrographic enema to ensure we did not have a perforation. Following that, after we confirmed we didn't have a perforation, the ileostomy was closed 4 weeks later. However, you develop a stricture again. 3 months after closure of ileostomy, the stricture on the left, it could even allow, it didn't allow a gastroscope to pass through. No, we have a different situation now. We can't be too aggressive in the dilatation. We could use Eguare's dilator to dilate the one he had previously, because there was an ileostomy. He had a protective ileostomy. In this case, we had closed the ileostomy. He had this. We had to do endoscopic bilum dilatation. We had to do endoscopic bilum dilatation of this stricture. We've injected Kenalog, triamcinolone. This is what we had. Post that we're able to dilate up to 13 mm. Triamcinolone was also injected. This is how it looked like. And after that, we're able to do a full colonoscopy for him. Went through the sigmoid, got to the cecum. He didn't have any residue. He didn't have any metacronius disease. He's had a pelvic MRI. He's had a CT scan done to show that he's doing very well. However, I'm going to burst your bubble. He's complaining of difficulty in passing stool occasionally now. I've not seen him. I'm supposed to see him again. So that tells you the problems we have with strictures when they do happen. They can actually be very difficult to treat. Lesson we learned from this gentleman was we thought we could get away with doing a low anterior resection without a protective colostomy because the radiation he had was 5 weeks before the surgery. That was a hard lesson we learned. The histopathology of his tumor, of a resected tumor, turned out to be T3NOMX. Of course, it should be preceded by the prefix YP because he had total neoadjuvant therapy. And what did we learn? We thought the stricture evidently developed due to a combination of the chemoradiation, the leak he had, and by virtue of the fact that we used titanium staples. Of course, the 3 factors were at play. I think the major factor was probably the leak and the chemoradiation, right? So henceforth in my institution, low anterior section, any patient that's had prior chemoradiation usually have a protective stoma to reduce the likelihood of anastomotic leak and strictures. That's the lesson. All our patients that are undergoing low anterior resection, that have had chemoradiation before coming to us, they usually have a protective stoma. In this day and age, all patients, if you use the harmonized NCCN guidelines for sub-Saharan Africa, which I expect everybody to be using, if you have a multidisciplinary team in your hospital, all your patients with rectal cancer, especially locally advanced rectal cancer, will have had total neoadjuvant therapy before coming to you. So evidently, you need to do your low anterior resection with a protective stoma in order not to have an anastomotic leak and possibly a stricture. We were lucky the gentleman did not die. So what do we actually do in my center to prevent anastomotic leak? What do we actually do in my center to prevent? Of course, we follow the enhanced recovery protocol to some extent, but all rectal cancer patients will have a bowel preparation. They always have a bowel preparation. We try to do a tension-free staple anastomosis. We do an intraoperative air leak test. We do occasionally when the colonoscope is available, we insufflate with the colonoscope. We check our donuts. If we suspect a leak or the donut is not complete, the anastomosis is reinforced with 2-proline. 2-proline. So in a nutshell, what we've learned is protective stoma in all patients with prior radiation, especially in the context of total neoadjuvant therapy. These are the measures we adopt to ensure we don't have a leak. This is an intraoperative colonoscopy, right? The one on the left is white light, the other one narrowband imaging. You can see the anastomosis. We actually use the colonoscope to insufflate in this situation. Patient was operated. The patient has gone home already. This particular patient has gone home already. This patient was operated recently. He has gone home already. Now, the other challenge I've had is presacral bleed, but I need to say something. Presacral bleed is not a common thing in colorectal cancer surgery, but when it does occur, it's a life-threatening complication of rectal cancer surgery. It's not only in rectal cancer surgery, it could be in UC, you're doing a completion proctectomy and ulcerative colitis, right? It's uncommon, but it's also life-threatening. Because when you're doing your posterior rectal dissection, you can go into the wrong plane. You go into the wrong plane, you can damage the presacral plexuses and they start to bleed, usually due to incorrect mobilization of the rectum outside the Waldeus fascia, in which you now tear the presacral venous plexuses, and the bleeding can actually be torrential. It's usually torrential. In the past 4 years, why am I discussing this case? In the past 4 years, 4 years, we had 5 cases of presacral bleed. No, 4 cases. The first one, we didn't even know he had a presacral bleed. We lost the patient. Autopsy was the one that revealed massive hemoperitoneum. We could only have had massive hemoperitoneum from a presacral. We surmised that it must have bled from a presacral bleed. We lost that one. The second one was about 2 years ago. No, 2-3 years ago, because 2-3 years ago, must have been 3 years ago, because 3 years ago, patient had a low anterior resection. We noticed some bleeding at surgery. We left a drain. The following morning, we saw blood in the drain. We had to reoperate. We managed the presacral bleed. We using a combination of a number of hemostatic agents, bone wax, and gel foam, and Surgicel. That's what we're able to successfully manage. Of course, doing that, patient did well. Glory to God, the patient did well, and she's fine today. She's had a colonoscopy done, and that was about 3 years ago. She's doing very, very well. Why am I even talking about presacral bleeding? I said we've had 4 cases. One about 4 years ago, another one about 2 years ago. Recently, we just had 2 cases in the last 2 months. A 70-year-old lady who had total neoadjuvant therapy. He had total neoadjuvant therapy. Not only total neoadjuvant therapy, he had a hysterectomy 25 years previously. I had a hysterectomy when he was in his 40s. Then he developed rectal cancer, total neoadjuvant therapy. The surgery was a difficult surgery, unquestionably, probably due to pararectal fibrosis from the radiotherapy. Difficult dissection, was there for about 6-7 hours. Had gone into the presacral fascia. Patient bled. Unfortunately, we lost this patient. Then we had another 27-year-old. We recognized the bleeding at surgery. We stopped the surgery. We packed. We resuscitated the patient in ICU. Then came back about 30 hours later, after we resuscitated, for a relaparotomy. We managed the patient with hemostatic agents, bone wax, gel foam, Surgicel. I think we used another one. I can't recollect the name. We used everything. She's doing very well as well. So this is what you need to appreciate. This is what happens. This is what happens. This is the Waldeus fascia. This is the Waldeus fascia here. When you're doing your dissection, when you're doing it, you have to be extremely careful when you're doing your dissection in this area. You don't damage the sacral plexuses, because behind the Waldeus fascia, you have behind the Waldeus fascia, that's where the presacral fascia is. Once you damage things, they start bleeding from the presacral venous, usually torrential bleed, usually a very torrential bleed. Torrential. So, but you still have to master how to do it, because no matter how good you are as a surgeon, so long you do all this total mesorectal dissection, you do rectal cancer surgery, you're still going to have a bleed one day, no matter how good you are. But what's the pathogenesis that I mentioned? Incorrect mobilization of the rectum outside the Waldeus fascia. Outside the wall, can tear the lower presacral venous plexuses or the sacral basivertebral veins, causing what may prove to be uncontrollable bleeding. Nobody does blunt dissection again. If you do a blunt dissection there, you're supposed to do, when you're doing your total rectal dissection, you're supposed to do sharp dissection. If you do a blunt dissection, which is akin to a pelvic rape, you can cause, actually one of the commonest causes in untrained hands. How do you manage it? Packing? You can either pack. I've done that one. I've never done, you can tack the bleeders or use topical hemostatic agents. Electrocautery apparently does not work very well with presacral bleed. It does not really work very, very, but you could use it direct or indirect. But the commoner ones, the ones I've used, is packing and topical hemostatic agents. There are different ways of packing. There are quite a number of ways of packing this. You can pack with Surgicel, you can pack with other hemostatic agents. Fortunately, if you pack with Surgicel or hemostatic agent, you don't have to do a redo laparotomy. But if you pack with the abdominal pack, you have to go back and do a redo laparotomy to remove your pack. Yeah, the other therapeutic challenge I am going to discuss is young lady. No, I won't say young lady, she's 53. She had rectal cancer, locally advanced rectal cancer. She had neoadjuvant therapy in form of chemoradiation. Following chemoradiation, she had pelvic MRI about 8 to 10 weeks later. She was adjudged. The circumferential resection margin was free. That's what, because we actually discussed the pelvic MRI at a conference between radiologists and general surgeons. We usually do that before most of our surgeries. We discussed it. So patient had low anterior resection. I did tell you that anybody that's had a radiation will have a protective stoma. So she had a low anterior resection and a protective stoma. Was operated on Thursday, went to on Monday. Everything was fine. But I need to also say something. While at surgery, so we could have a clear plane for our dissection, she had a huge fibroid. So we called in the gynecologist to do a TH and a BSO. We need an intraoperative consent from the husband to do this, to do a TH and a BSO. So before went ahead with the surgery. The shocking thing after surgery, after she had gone home, the pathologist was the one that even called me that the CRM was involved, the circumferential resection margin was involved by the cancer, the ovaries that we didn't plan to remove were involved by cancer. So this was 14 months ago. She eventually had chemotherapy because of her status. After she did a colon panel, because we're now dealing with an M1 disease. They did KRAS, they did MSI, they did everything. She had to use the cetuximab. We've since closed her ileostomy recently, which would be about 1.5 years ago. Recently, a recent MRI revealed that she has a thickening of the distal rectal wall with no diffusion restriction. However, there's a small mesorectal adenopathy measuring 17 by 17 mm which showed diffusion restriction on DWI sequence. We don't know how to manage this patient now. We really don't know. It's not as if we don't know how to manage this patient. It's not as if we don't know how to manage this patient. The shocking thing is, one, she had a metastatic disease at surgery and we didn't know. Despite the fact that we reviewed the MRI. Despite the fact that we removed how that happened, we still couldn't unravel it. This is the final therapeutic challenge I've faced in the last 2 I'm discussing. Thank you and questions.
Thank you very much, Dr. Osinowo, for this presentation. Very honest and very pragmatic too. I'd like to hand over to Mr. Emmanuel Eguare, International Rapporteur, to take the question and answer and other comments. Thank you.
Great. Thank you so much, Dr. Osinowo. This is a very transparent conversation, and I thank you so much. And I think it really brings the challenges of colorectal cancer to the fore. And I think you've just really given us some further for discussion. Thank you so much. And I think there are so many lessons we all can learn from this. Please, I want you to post your comment or your questions and comments on the chat box, or if you want to ask the questions verbally, you can signify by raising, using the raised hand symbol. Please, can we stop the presentation so we can see everyone on the screen? So that
Should exit.
Yeah, maybe just to stop here. Stop it.
Just stop sharing, sir.
I should stop sharing.
Yeah, so that we can see everyone.
Yeah,
yes.
good. Yeah, all right, good.
Yeah, thank you so much, Dr. Osinowo. Yeah, I have a few maybe comments to just point out the insufflation at when checking your anastomosis. Using a rigid sigmoidoscope is much more easier to assemble rather than bringing the endoscopic stack into your theater and all that. Just use a rigid and you can look at the anastomosis under vision and you balloon and do another underwater insufflation. I don't know what you think about that.
It's just I had the luxury of a scope in my theater. That's why I used it.
Okay.
Actually, ordinarily, what I use is if I don't have a scope in my theater, I just use a catheter, a 24 catheter, and a bladder syringe, and insufflate.
Yeah. Okay.
That's what I do. You inserting it. It's because I had the luxury. I was fortunate to have the colonoscope in the theater that day. That's why I used it. I don't use that regularly. But the other option is you put in a catheter into the rectum above the anastomosis, above or below the anastomosis.
No, below. That's a bit below, and then you clamp above it.
You can do. Yeah. But the most important thing, and attach a bladder syringe, then your assistant will have clamped the bowel. In a non-crushing forceps. Then you insufflate. You add water. The patient is now reverse Trendelenburg. Patient reverse Trendelenburg. Warm saline is poured into the pelvis. Then you do that. Yeah.
Great. Thank you very much. And then the issue of the sacral bleeding. I remember the tags are very, very cheap to obtain. You know, these thumb tags.
I've never used them before, sir.
Oh, they are very. In those days, we used to have sterilized thumb tags on the operating table. So if you have a bleeder, just press one onto this bleeding spot into the presacral bone. It stops the bleeding. Yeah, it's I mean they are very thumb tags that you get that using pinning papers on the wall.
Yeah, I know them.
Yeah, they're sterilized, and you just put one there and you leave it there permanently and just tell the patient, because subsequent scans will show a hyperresonance in that area, but they are very efficient. And the other thing is, which I think we all should learn here, is packing is so important. Packing with Surgicel will not be as effective because for you to have enough Surgicel to pack the pelvis, that you'll be spending a fortune. So what you do is just to put a 30 centimeter pack and pack it and pack it and pack it and close up and bring the patient back in 48 hours, 30 to 48 hours to take out the packs. Most oftentimes than none, the bleeding would have stopped at that stage. So rather than trying to stop the bleeding at that point where you end up the patient losing a lot of blood, just pack. And sometimes you may just pack and hold the pack there for you ask your registrar, your SHO to hold the pack while you go for a cup of tea. And then you come back and see how it is going. But I think the packing is so important to temporize the bleeding, and most times it will also help. The other question I wanted to find out, when you dilated the anastomotic stricture, you say you came back 4 weeks later to close the the ileostomy. And did
Yes,
you
sir.
reassess the anastomosis at that point before closing the ileostomy?
No. The original surgery, when we're doing when the gentleman had a leak, when the gentleman had a leak, when we were fashioning an ileostomy for him, we repaired it. We repaired the leak there.
Okay.
We repaired the leak then. That's when we repaired the leak. We repaired the leak and fashioned an ileostomy. We did it in about 40 minutes.
Okay. No, what you said, you dilated it. And
Yeah,
then,
I dilated it.
yeah,
I
4 weeks
dilated it.
later, you brought the patient back to close the ileostomy.
Yeah, I dilated and I waited for 4 weeks. I still did a gastrography enema. Then I just wanted to wait for 4 weeks. I wanted to wait for 4 weeks, but then I closed the ileostomy. Unfortunately, he had the stricture again.
Yeah, because strictures are notorious. They reoccur.
No, strictures are notorious.
And one
Strictures
of
are
the things,
notorious.
yeah, it's once you have a stricture, once you dilate and you close the ileostomy, you should bring the patient back quickly to do further dilatation and subsequent dilatation until you're comfortable that the ileostomy and the stricture has stayed open, if
And
not just reoccur.
one must dilate up to at least 20 ml.
Yeah,
You must dilate up to at least 20 ml if you are using a balloon.
yeah. Anyway, so those are some of my um, questions, and yeah, and then the other thing you talked about in the early T staging surgery with the watch and wait, you did highlight the importance of an MDT for
Yeah.
following these patients up in the watch and wait protocol. But my question is, this is an environment where you have ready access to or regular CT, MRIs, predictable MRIs. How feasible is this, having a functional MDT and availability, access, and affordability of the MRI to follow these patients up?
Sir, because one thing is the downside of which you want to offer a patient watch and wait. You and the patient must sit down and discuss it. The patient must be ready to do MRI every six months. He's going to do a colonoscopy, at least a proctoscopy or a colonoscopy every 3 months to assess the area. It's a difficult thing. I've only managed one patient for watch and wait. Just one patient. One patient. That's one patient. And I started managing the patient about a year ago. He has done colonoscopy twice. He has done colonoscopy twice. He has done MRI twice. It's still good. But it's difficult. I'm going to tell you it's difficult because you have to you're going to do all these tests. Fortunately for me, I do endoscopies as well. So it's very easy for me to do a colonoscopy for the patient. I do a colonoscopy, I do a detailed rectal examination, I do my colonoscopy. He does an MRI. We go and sit down with the radiologist and discuss the MRI. That's how it works.
And you need a very good radiologist.
Unquestionably.
Great.
Because
Thank you very much. Yeah, I think there are a lot of questions waiting for you here. So you can get just want you to sip some water there. And
And I saw a question about. All right, maybe I should.
okay, maybe we'll go through them.
I
Dr.
think you should go through the
Olatungosu,
questions
yeah,
so that
Dr.
I can see.
Olatungosu, okay, has his hand raised. Maybe we'll start with him and then we can go through the chat. Dr. Okay, you are muted.
Thank you, sir. Thank you, sir. Good evening, everyone. Thank you, Dr. Osinowo, for such an honest presentation. It's brought up all sorts of memories and a few comments and contributions based on my modest experience. So regarding presacral bleeds, when they come, just as you said, they can be very nasty and messy. In my own experience, just like yours, I realized that packing is a fantastic tool, and you could pack and come back the following day. You pack, you send the patient to the
I see.
HDU or ICU and come back the following day to sort it out. More often than not, the bleeding has stopped. Mr. Eguare spoke about the thumbtacks. I don't have experience with that, although it's something you always have to talk about in colorectal exams. And there is another thing that Gordon and Nivat Vonks spoke about several editions of their book ago, which is the use of muscle welding. In other words, you take a bit of muscle from maybe rectus abdominis, you place it against the bleeding point and diatomize it until it sticks. I've never tried that, but in all of this, I think packing works perfectly. But in order to prevent it, in my opinion, we cannot overemphasize the need for firm traction to demonstrate the so-called angel hair, in the holy plane, because the idea is to stick to the holy plane and dissect slowly. There is no need to be a fast surgeon. If you're going to be a surgeon that will keep having presacral bleeds, you eventually have so many more mortalities in your. So you dissect slowly. The lower down you go until you get to the U. Even when you get to the U curve around the beginning of the Walde's fascia, you can still retract strongly forward, and you still see angel hair, and you can just stay just outside the mesorectal fascia that we spoke about. And I think that way, while it is true that as long as you're a rectal surgeon, at some point you're going to have this and it's going to humble you, we can reduce the incidents in our practice. The other thing I wanted to talk about, so I think we had discussed this in the General Surgeons Forum, the Lagos General Surgeons Forum some time ago, is the importance of the MDT, which you spoke about, and the nuanced decision making that an experienced MDT will bring into managing rectal cancers. Why do I say this? Because these days the goal is organ preservation as much as we can. It is possible these days to, in some parts of the rectum, and even with the same stage, for example, with the same stage, say a stage 2 or early stage 3, it is possible to skip radiotherapy in the mid rectum, upper rectum, for exactly the same stage that you give TNT to in the lower rectum, with the aim that because even radiotherapy worsens the function of the residual organ even after the patient has been subjected to that. So the MDT helps with this nuanced decision making. And just as you said, we need an experienced MDT for that kind of thing. Now, finally, the stenosis that we spoke about. Well, once there is a leak, I think we should expect stenosis. But even the question is, why was there a leak? Yes.
Okay, thank you
Hello,
very much, Dr. Okay.
I lost you
That
there.
a leak, we know there is a 15% chance that a leak could happen. But the reality is the blood supply. So, I mean, these days, surgeons are increasingly using indocyanine green, fluorescent imaging to monitor blood supply and a host of other things, that appear in special cameras in the theater. And I think that the lower down we go, if we're going to work without these special adjuncts to good surgery, just like you said, I don't think it's a bad thing in our environment to still make a protecting a defunctioning ileostomy a routine thing. Obviously it will require a knowledge of stoma management. We may need to train nurses and all that, but we're going to have better outcomes with time. Thank you, sir.
Yeah. Thank you very much.
Thank you so much, Dr. Okay, for your comments. Yeah, one other health warning we just need to give is that an ileostomy does not preclude a leak. It might reduce the symptoms of sepsis or presentation subsequently. So, like Dr. Oke said, ensuring the circulatory integrity of the gouty anastomosis, that is so important to ensure that the anastomosis is not under tension.
Yes,
And that's another important thing that we need to take note of, because if the anastomosis will leak, it will still leak, but it may not be as overt if you had an ileostomy. They might just be, they present as a subclinical leak, but we take that on board. But I'll just go through some of the questions here. The first one is from Dr. Ibrahim. He says, beautiful presentation, sir. All the cases of presacral bleed were females. Could the anatomy be a risk for presacral bleed?
If you look at the literature, yeah, the female pelvis is actually wider. You are not supposed to have you shouldn't have a presacral bleed. I think it's just serendipity. That's what I can say. Just I can't really tell you why. You expect it to be you expect more difficult surgery in a male with a narrower pelvis. So I can't really explain that. I think it's just serendipity.
Great, 100%. Dr. Lawa Adeyeye asking a question. Thank you for the insightful presentation, sir. Regarding timing of surgery post-chemo radiation in TNT, will waiting for 12 to 16 weeks before surgery not make the surgery more difficult technically?
No, let's put it this way. Look, the Nigerian patient is a bit different. Patient has chemo radiation first. Chemo radiation is is about 25 days. 5 times 5 is actually 28 days, right? They wait for 1 month, they have chemotherapy. They now have they now have chemotherapy. Is after chemotherapy, they wait for 1 month, they now have chemotherapy. Chemotherapy is for how many weeks now? It's about 12 to 18 weeks, right? After chemotherapy, you have to wait for another 1 month to do your pelvic MRI before you consider a patient for surgery. I don't think it's long. I don't think it's long. I don't think so. Even your Nigerian patient is not going to follow that schedule because they're probably going to be money with finances and that kind of stuff. So I don't think it's long. But that's the standard. That's the standard.
Okay, thank you. Dr. Zaharaddin Wada says, thank you, sir, for the presentation. What size of circular stapler do you use usually, or do you usually use for rectal anastomosis? Dr. Osinowo seems to have disappeared while we are waiting for him to reconnect. And I think your choice of the size of circular stapler, this is why you use your sizes before you choose your sizes. You should have all the sizes available to you, because you have to be able to insert it into the anal canal. It has to be able to get to the rectum and the rectal stump without applying undue stress on it, So whether it's 28 or 30 or 29 or 31, but if you use your sizers to actually check the rectal circumference, and that will guide you. So you just can't choose one, particularly in an area where these things are expensive. You don't open a 31 and suddenly discover that 31 is too big and it can't go through your inner canal. So I think the benefits of using your sizers before you choose the size of your circular anastom or circular stapler is important.
Sir, can I just make a comment on the sizes, sir?
Yeah.
Thank you, sir. The one of the challenges we find in Nigeria is that it's expensive and very difficult to get staplers. Many times, at least from my experience, that you'd actually have to request for the stapler before the surgery.
Sorry. I use a 29 stapler all the time.
Okay.
I use a 29 stapler. I know some people use 31 and 33, but I customarily use a 29. I've used the 25 once. But I customarily use 29.
Yeah, I think again that's. I mean, if 29 would be middle of the range, which is a safer bet than going to the upper margin of 31. 31 may be too big, and 28 is okay. And I think 28 is okay, even if you have 28 to be safe. It does not increase the risk of strictures. So the size you use does not increase the risk of strictures. What increases the risk of your stricture is more with the blood supply to your stumps that you are anastomosing. That is what is really more of ischemic strictures most often. So the sizes, as long as your stapler can go through the inner canals conveniently, and the anvil on top, you can actually insert that into your proximal colon and create a pulse string and get a proper one without undue tension. I think that's the most important thing. So I agree with the president and Dr. Osinowo. If you don't have the choices, then go for the middle of the middle range. That's something that will go into every rectum.
Yeah, can I just add to that? I was just trying to complete my statement that yes, 29 is what most people want to use and recommend if you don't have sizes available, because you don't have the luxury of having a choice of staplers. You have to request for a stapler even before the surgery. So you have already predestined the patient to a particular size of stapler. So 29 will probably be the safe bet. The challenge there is that sometimes I'm not publicizing any company or advocate for any company, but sometimes there are some size disparities between companies. So when we use 29, we are assuming that we're using the Ethicon staplers. So for other manufacturers, they actually have sizes that are different from the configuration of Ethicon, and so we will have to find that corollary if we're using a different stapler from what we're used to. And then one other issue is to make sure that we get the stapler firing right, because if a stapler costs more than the entire surgery and there is a misfire, then there's an issue in there. So we may not have the luxury of having to do a second firing or having multiple firing, which increases the risk of strictures and is also more costly. And then of course we have to have a plan B if the staplers do not work well and then there's a leak on our air leak bubble test, and how to deal with that situation. So I think those are things that we need to consider. Thank you.
Thank you so much. Dr. David Irabo has a question here. Why do you protect your anastomosis with ileostomy? Why not transverse loop colostomy?
I think I need to tell you the truth, right? I used to use transverse colostomy before. I just got used to doing it. I think I went somewhere, I saw them using an ileostomy, because the ileostomy leak is actually a bit more, because I wrote a paper on ileostomy and colostomies. The ileostomy leak is actually a bit more than colostomies. I just got used to doing ileostomy because I think it's a bit easier. That's why I use it. That's why I use it. It's not a hard and fast thing that I have specific reasons why. I can do a transverse colostomy. I can use an ileostomy as well. A transverse loop colostomy. I can use either of the two.
Yeah.
I just think an ileostomy is easier for me. I think it's ease.
Yeah.
Maybe I'm lazy.
And I think, again, it's easier to close. And if once you you perform your ileostomy spouted, then the leak is much more, the risk of leakage is low. So, and when you are closing it, mobilizing it, and using a stapler to close it and just push it back in. And a colostomy must be so difficult. I haven't used colostomies, but ileostomy just, well, we're taught to do that, and we just used it, and it's much easier, really.
Can I comment on the ileostomy and colostomy issue? Because it's a common debate in exams and, of course, in practice too. The reason why there's an argument against ileostomy in the tropics is because of the functional complications of an ileostomy.